Afternoon Tea with Docs. My name is Dr. Linda, emergency medicine physician from Sheffield, and I'm here with my amazing co-host, Dr. Erica, who is a GP from the West Midlands, and we are both board-certified lifestyle medicine physicians. And we have an amazing guest for you today. No other than GP from the West Midlands, and we are both board-certified lifestyle medicine physicians. Well, technology does go wrong sometimes. Wow. No other. Sorry about that. We have an amazing guest for you today, Dr. Elizabeth Arnold from Somerset, and we are going to talk about her incredible results in the NHS, where she's using lifestyle medicine to help her patients actually reverse type 2 diabetes. And so if you're new to us, welcome to Afternoon Tea. Our story started when we were thinking with Dr. Erica and our amazing lifestyle medicine colleagues about the fact that virtual group consultations, where we deliver lifestyle medicine education, followed by coaching in a very supportive community setting, can actually reverse our patients' lifestyle-related diseases, such as type 2 diabetes, as we will speak about today, heart disease, hypertension, hypercholesterolemia, and even bowel and breast cancer. The science is clear. So it was a no-brainer for us. Of course, we needed to make this education and coaching freely accessible to all of our NHS patients and bring this service globally. This is why Afternoon Tea with Docs was born, where you can join us every single Sunday at 5 p.m. UK time so that you can transform your health. If you're new to our social media, do say hello to us on Instagram, Facebook, and LinkedIn, where you can say hi and let us know what lifestyle changes you would like to implement. And if you're ready to actually implement those, why don't you become a member on afternoonteawithdocs.com/members, which is a completely free of charge platform and community where you can learn how you can put this amazing education into practice. So thank you very much. And Erica?
So today, as Linda already mentioned, we've got Dr. Elizabeth Arnold, who is a GP partner and diabetes lead in a Cardiff GP practice. She's also a CHIP facilitator with an interest in lifestyle medicine and also a special interest in menopause. She also runs a private virtual menopause clinic that incorporates lifestyle and hormone replacement therapy management of the menopause at Summerfield Healthcare.
Hi,
welcome, Liz.
Welcome. Thank you so much for joining us. It's incredible to have a colleague who is so committed to actually bringing true healing to their patients. Dr. Elizabeth, I would love to start today's sessions with your incredible results that really blew us out of the water. Could you just share us what are the results that you had with your patients when you helped them put type 2 diabetes into remission?
So this is just two examples from my practice and just lately over lockdown. So two examples are both gentlemen in their sort of 50s, 60s, both diagnosed with type 2 diabetes. One of the gentlemen just nudging into the type 2 diabetes range and no sort of symptoms associated with it, but also with hypertension. And the other gentleman had the features of type 2 diabetes. So he, thirsty, weight loss, very tired. And he consulted with me, first of all, with weight loss, and then further investigations led to it. So he had a very high hemoglobin A1C, which is the sugar level that we look at, what's happening with your sugar over the last 3 months. And his level was 132. Just now, I've just checked him recently, and his sugar level is down to 41, which puts him in a kind of remission category. He has come down off nearly all his medications. So he started off on 2 different types of medications at high doses, and we've managed to reduce him down to just 1 tablet of 1 medication. So he's just on 1 500 milligrams of metformin. And I told him that if he maintains that, next time we check his bloods, I will take him off that medication and he can carry on diet, lifestyle intervention only. which is phenomenal considering that he was quite ill from the type 2 diabetes as well. And the other gentleman, he took it really on board, and he didn't want any medications. He was, for his diabetes, he was already on antihypertensive medications, and he just sort of said to me, what can I do? And we had a chat during a phone call, because it was during lockdown when we were triaging our appointments, about what he could do. He admitted that he used to love walking, and he used to go out walking most days. He used to go out hiking with friends. And because of lockdown, he didn't really feel comfortable with doing that. I think it scared a lot of people, and he was doing that less, especially during the winter. And he felt that he could engage with that a little bit more, and also that he could make changes to his diet in order to bring his weight down. So he engaged with it all. He actually has put himself into remission through the lifestyle changes that he's made. And I have taken him off all his hypertensive, all his blood pressure medication as well. So, I mean, just two examples of phenomenal results where lifestyle medicine has really come into play for them in order to avoid medication or to come down off medication, which is phenomenal.
This is incredible. I am so happy just hearing these numbers. One of your patients actually had an HbA1c of 131.
Yeah, so he was, yeah,
that is
32, just, but he's one of the highest that I've had, which is just, so normal hemoglobin A1c, which is your diabetic measure of your diabetic sort of sugar level over the last 3 months. That's what we're looking at. And in order to diagnose type 2 diabetes, you'd have 2 levels 2 weeks apart that's over 48. Anybody 42 to 47 is pre-diabetic, and anybody less than 42 is not diabetic. So, or in remission if you can get there with sort of lifestyle changes. So to be 132 is pretty sick with diabetes, and probably had diabetes for quite some time actually at that level. And then you start to think, what other damage has that done? But he was somebody that was very much against medication and very motivated and asking for help to do something about that. And at that time, I'd just qualified as a CHIP facilitator, and as part of our training, and I did explain to him as part of my training, he'd be a guinea pig for me. We're allowed to do a friends and family group. I decided to do mine with a few patients from the practice. So that involves, it's quite intensive. It's although you can space the sessions out, we decided to do it once a week. So we did it once a week, starting roughly in sort of a May time and running through the summer. One of those sessions overlapped with my summer holiday, but because it's over Zoom, I Zoomed them from Croatia, which was lovely. So I got to see them. We kept it going through the weeks. So quickly between the beach and going out for food, managed to do a Zoom session whilst we were away. But it goes through sort of all the pillars of lifestyle medicine that we've talked about on these sessions before. One of them, sort of big one with diabetes, is nutrition. It's about, as we're aware, cutting down the sort of saturated animal fats, trying to eat a whole food, plant-based diet. This particular gentleman loved a fry-up. He loved a fried breakfast. He was wholeheartedly a meat eater, also liked his treats as well. But he and his wife, he was the main cook in the house, were really keen to engage it. She actually went through this with him, and he embraced the food and got on board with the nutrition. He even told me one time that him and his golfing mates had been out for a full breakfast, and he chose the vegan option on the menu. He was very proud that he chose that, and he told me that as well. And you've changed my approach, and this has changed my approach to nutrition and making me feel well. Because as he went through the program, he lost a little bit of weight. He actually lost a lot of weight because of the diabetes to start with, but he lost a little bit of weight and normalized his sugar. And because he was feeling so well and able to get round the golf course, and his friends said that he was looking so well. He also managed to increase his activity levels up, which was brilliant. He said that he had a dog. The poor dog was going out for a walk twice a day. He said, I don't know what the dog thinks of all of this, but we go out in the mornings and we have a walk, and then we go out later on. And so the dog got a lot fitter as well during the process, which is lovely. And then he found that he was sleeping better. He had a lot more energy to do things, and he was just generally feeling better in himself. And his wife was as well. She did it alongside him. I think it helps if you've got a support person in the house with you, but it is possible to do this. I do this on your own. So the other gentleman, he didn't do the CHIP program. I had a consultation with him at the surgery. He was very motivated. He also knew a little bit about nutrition. I offered to refer him to a dietitian, which we do with all our new type 2 diabetics. And he said, no, I'm quite happy. I know what I should be doing. I just need to implement it. His wife was a district nurse, so she knows as well. And he says, I just need to get back out walking. I just need to get my activity levels up. I need to sit less, and I need to get out there and just go. And so he took it upon himself to just go out walking. And I see him out and about when I'm sort of driving around in the car. I see him out walking now, and he looks so much healthier and so much fitter. He has dropped his weight enough to come off his hypertensive medication completely, and he has now also put himself into remission, which is great. And he did that just with he knew a little bit as well. I mean, some people really don't have a knowledge about nutrition, and it's really, really hard, I think, with all the information that we're being fed at the moment. But he sort of knew where he was going with it. And just sort of ahead of this talk, I Googled diets for diabetes, which you would do, I think, if you were told that you were diabetic. It's really confusing. It's really, really confusing. Diabetes UK popped up, which is great. So that's a good resource. But also these diets that are low fat and into weight loss quite quickly. So the ones where you drop to 800 calories a day, or you're on meal replacements 3 times a day, which has a place for some people, and if that's what you want to do, but it's not sustainable or recommended long term, and also doesn't fit in to family and working life either. And I think engaging with sort of the freshly cooked, if you can, whole food, plant-based program is easy just to incorporate into your everyday. Along with that, the choices of food for some people are quite hard. I have another patient that a couple of months ago, he's recently come out of prison, and he said, and his hemoglobin A1C has shot up. And I've had a chat to him, and he said, in prison, my meals were provided and there wasn't any choice. He says, now I buy a newspaper, I have to walk through all of the displays of confectionery and all of the other sort of fizzy drinks. He said, I go and buy petrol, I have to walk down the aisles to the checkout, and they are everywhere. And he said, there aren't any kind of fresh fruit options there if you fancy a snack. And he just said, this is a nightmare. He says, I do have a sugar addiction, and I'm finding this really, really hard. And I think acknowledging that and speaking to people about that is important, to try and get them on board and engage with any kind of program that you want them to do. And it's and like I said with him, it's making the little changes. It's making the little changes every single day that then can hopefully become your new habits. And then if they're your new habits and they're healthier for you and you're feeling better, then just go with that and stick with it. And trying to sort of encourage people to engage with that, to look after their future health, because that's what we're doing with diabetes. We're not just bringing down the sugar, it affects your kidneys and your eyes, affects your peripheral circulation, so you can get changes sort of lower down with your feet. It affects your heart. So there's lots of things sort of further down the line with a persistently raised sugar level that people don't realise that is dangerous for them.
It's an incredible result, one that we see over and over again. But seeing it really practiced in the NHS as it is right now, how busy it is, and done by a GP within a GP setting that we know too well, where we are now, so many of our colleagues are burnt out. There's only 10 or even less than 10-minute consultation appointments. And where a lot of the office work actually continues into your off days. All of this really compounds into a very stressful environment. How are you able to do that? And how do you think this could change the future of our NHS?
I mean, it has been hard during COVID because we've had to switch over to telephone triage. As GPs, we're not happy with that. As patients, they're not happy with that. But it's the guidance that we had, and it was the only way of keeping everybody safe. And also because of the huge uptake, treating people on the basis of need rather than want. So it's been unpopular all round, and we've been working like that for 2 years now, and it's not getting any easier because the people that were sort of in the emergency situation and contacting you in the first few weeks, all the other people, their problems have been left. So through that, we have been monitoring blood tests, and we've been there for people, and we have been looking after people. In my surgery, my diabetics have still had their blood tests. They've still had their reviews, albeit over the phone, but they've still had the opportunity to talk to us about sort of lifestyle advice as well. And now we're looking at, and a lot of practices where I am are looking at now going back to bookable and face-to-face appointments next month. It's going to be hard for everybody transitioning back into that model. Quite a lot of people actually like the telephone system. So we're now trying to do a mix of appointments, sort of telephone, because you don't necessarily need to see somebody face-to-face, even though that people want to do that. And I do appreciate that. And also, we've missed seeing people face-to-face. I actually like seeing people, like sitting down and having a chat with people and seeing people face to face. So it's been really hard, I think, for everybody. And we have been seeing people face to face on a basis of need, and bringing people down to the surgery, but you just can't have a lot of people sat in your waiting room. And they're mixing also with people perhaps who've had chemotherapy or are on immune modulator drugs, and they are vulnerable people and on the vulnerable list and at risk. So it's about sort of managing that.
And there's a huge rise of patients who have been flooding into A&E as well as to GP, but of course there is only so much resources do we have. And after the pandemic, we saw that by increasing the bad side of the lifestyle that was promoted by staying at home, lockdown, loneliness, increase of alcohol consumption, and unfortunately increase of processed food in most cases. But of course, there were some cases of patients who went the other way. But the larger population, due to the lack of education, has actually showed what we have been seeing the last 50 years through the pandemic of chronic diseases, exacerbated over the last 2 years. And this really has shifted our waiting time in A&E from about 4, 5, 6 hours to even 16 hours. And you could just really see that high peak due to the exacerbation of chronic diseases that patients already had. So with your results that we have seen today, which are incredible, but not unheard of nowadays with lifestyle modifications, do you think it's a solution that we could bring into the NHS without a huge reform to help our patients reverse their chronic diseases so that we can plummet the number of chronic patients that we have, and thus also improve the crushing effect on our NHS?
Yeah, absolutely. I think there are simple, effective ways of doing this. I mean, just we're guided by the NICE guidance. All the NICE guidance for all the chronic diseases, number one NICE guidance is lifestyle factors for all of them. And I think that it's quite easy to skip over that, because it's almost right, if you move a bit more, if you eat a bit healthily, right, let's give you the pill because that's next on the list, guidance number 2. And it's just, it's having the time to do it, really. I think the time constraint is the main one. And it's also getting people to engage. I think people need empowering, and they need educating. And it doesn't have to take very long. And the messages, I think, need to be kept quite simple, because it's not rocket science. It's not hard. And I think that you can just, within a 10-minute consultation, which is what we have in general practice, you can impart quite a lot of knowledge in that time, and with the internet, direct people to appropriate resources to read further and to engage with it. So, I mean, there's dietitians available, but then there are diabetes, we've got Diabetes Cumbria, there's Diabetes UK, there's the British Heart Foundation. They've all got sound dietary advice on there. So you can go and educate people about where to find more advice on how to eat well. There's, we've got an exercise referral scheme that we can refer people into. I have to say, though, that that is in a gym, and that really, really doesn't appeal to everybody. So I would say that if there's something that you've been fancy doing, or something that you did as a child that you really engaged with, whether it's a team sport or whether you like walking, just increasing up activity level to get yourself moving more in the day. And I appreciate that a lot of people are working from home now, so spend 8 hours sat down. And a lot of people, we now have call centres where a lot of people work, and your job is sedentary, and it's about making little changes in that time in order to get moving and more activity. So I think, there's just 2 aspects of the lifestyle medicine that you can cover quite easily in the consultation. And I think encouraging people to sleep well, talking about sleep hygiene, that's quite a simple couple of minutes conversation, and then they can go and have a little bit of read about that and about how they can engage with sleeping better and reducing stress, and different factors that you can put in about reducing stress. And then I think sort of patients have to be receptive to this as well, and that's hard. And sometimes they have to admit that maybe what they have been doing isn't making them feel so great, and they've got to make a change, and it's making that change, really. And I think that's very hard, because we've got time constraints at the moment with people. Everybody's got busy lives and they're working, and I think sometimes you have to prioritize these things in your life in order to maintain your health. I think if you've seen, Linda, as well, that the NHS can't continue as it is with the level of chronic disease. And I think people are going to have to take some responsibility for their own health and engage with it, and not just for a week or so, but need to make lifestyle changes for their lifestyle, really, so that going forward, we can have a healthier population. And if you engage with that, the children, if you have children in your household, will also see what you're doing and acquire the education and the knowledge, and that will be normal for them to eat healthily and eat well and engage with activity. But we are fighting against a little bit sort of technology, and maybe just out of habit, really.
I think it's very important that you, a clinician who really believes in their patients, who really look at their patient from a holistic point of view, radiates this energy towards them that makes it believable for them and possible for them to put these very difficult lifestyle changes in place, difficult as per their perception. And I think what you did amazing here is that you went out of your way, got a little bit of an extra training on top of your general medical practice training that you do every single day, just so that you can bring that little extra into your consultation so that your patients can really take it home. Because I believe there is something still about a doctor telling this information in a smart prescription where they can actually know how many times in a day, in a week, they can implement healthy nutrition, exercise, and sleep was really the magic. Do you think so?
Yes, I do. Yeah, and it's interesting because I took over the diabetes in my practice from one of our GPs that left. It's quite a heavy chalice. It's quite a big register of patients. We've got roughly about 10,700 patients in my practice. On average, practices have about 5% of their population type 2 diabetics. We have more chronic disease in Wales, so I think mine's probably nudging 6.5% of type 2s. And when I took over, I was just, the numbers of medication and the number of people just not doing very much about it. They didn't seem to be bothered about being, it's just like, right, I'll have a tablet and this will be fine. And then you add in more tablets and you add in more tablets and more tablets, and then you refer to the hospital and they're put on insulin because their pancreas stops working. And it's just, and I sort of thought, well, what if we could do something about this before it gets to the diabetes stage? So I then had a little look through the register, did an audit of those people, again, going back to the hemoglobin A1C, so the pre-diabetics. I had a little look at the pre-diabetics, and I just thought, what if I can actually get to these pre-diabetics before they become diabetic? What if I can do something for them? Because we were just sort of coding them as pre-diabetic, and right, we'll just watch then. It's pre-diabetic. Okay. I had a bit of a chat with one of my nurses about what they could do about that. I'm not sure if they really totally engaged with it or understood what they could do with it. And I just thought, well, we've got to do something about this. I've got far too many patients on too many medications to look after. This is really time consuming and not good for them either. And it's costing the NHS a fortune. It's 10 billion a year. It's costing the NHS for diabetes. So I did the audit, had a little look, and I got two lovely ladies from Diabetes Cymru to come into my practice. And they had groups of people. We did, this was before lockdown, we had groups of people in our conference room upstairs. They very kindly brought some free pedometers, and they had a chat to these group of pre-diabetics that were invited in. And I just thought, maybe we can do something and maybe we can make a bit of difference here. And they all engaged with it. They were all educated, not that they weren't uneducated people, but just about sort of lifestyle, really, just mainly to do with the nutrition, a little bit on sleep, but also activity, which is where they concentrated on, because you just got an hour and you can't go through everything, and just sort of various foods to look at that were sort of high in sugar that they could do swap out. So really sort of taking it down to sort of that level, because people really, you're sort of told and then it's just sort of, right, I don't know what to do. So it was just trying to get engaging with people, and then check their bloods. I think we left it probably, because if you're pre-diabetic, it's every year, so probably check their bloods. And quite a lot of those people have put themselves back down into a normal hemoglobin A1C range. My main aim was that nobody would become a type 2 diabetic during that time. And I had one person that just tipped over to 48, so just in the type 2 diabetic range, but the rest managed to maintain or reduce their hemoglobin A1C level. And then from that, I just thought, well, what if I can gain a bit more knowledge that I can give in a concentrated form in a consultation about this? So I did a nutrition course with Monash University and online, and I did the prescribing lifestyle medicine course. I think Dr. Chatterjee is one of the lifestyle medicines doing that one, and then just thought, oh, actually perhaps I could engage with this a little bit more. And then I trained as the CHIP facilitator as well. So it's just trying to impart some lifestyle medicine knowledge in a way that everybody can relate to and embrace and understand. Otherwise, you have just landed with diagnosis. Yeah, sorry, Erica.
No, that's incredible, Liz. I just want to take a moment here to appreciate you as such a busy clinician, such a busy GP partner.
And a mom.
And a mom. Yes.
Happy Mother's Day, everyone.
Happy Mother's Day. And with your compassion and your care for your patients to do the best for them, by them, and you're taking so much time outside of, on top of you're already medical school trained and GP trained and everything, done all your professional exams, and still, taking so much time outside to learn more, to see what you can provide for your patients. I just really wanted to take a moment to appreciate that.
Oh, thank you. But I also think that, don't you think that's a reflection on our medical curriculum and our education?
Absolutely.
I felt that I wanted to do that, really, so that I went through GP training and knew sort of chronic diseases, went through all my GP training, MRC GP, did all of that. And it's just like, yeah, talk about lifestyle, move on, drugs. It's just like, oh, wait a minute, that lifestyle bit's really quite big and really important. And it was just not in the curriculum when I was training, which was a little while ago, but it might be now. I don't know what the current GP training is at the moment, but we teach registrars, we're a training practice. So I don't think it's changed too much.
No, I don't think it has. And actually, even Linda, in her emergency medicine curriculum, lifestyle is part of the curriculum. Yet actually, how much lifestyle medicine do we know? And we're talking about lifestyle medicine as if it's something different, something new. But this is information that we've had for such a long time. It's only that we've put the focus on the pharmacology, on the drugs, which are really important, especially when majority of our patients were dying from infections when the NHS was founded. And I think because of that, our training, the medical training, has been formed in such a way that we put a huge emphasis on that. But things have changed as society is progressing. Convenience is being prioritized. Actually, people's health are going the other way. Economy is going up, people's health going down, and chronic disease is massively taking over infections, prior to this pandemic. But this pandemic also reflects the importance of our underlying health. People who are living with chronic disease, they were all listed as high-risk patients. And, at the start of the pandemic, a lot of them were advised to be shielding at home. So that, again, reflects that actually our underlying health is so important. Yet, lifestyle is actually part of our medical management. It is really first-line conservative management that we've always had in our pocket, just something that we've never really been trained to utilize properly. And so it's nothing new at all.
Yeah, I also think it's quite hard because a lot of people sort of come thinking, oh, the doctor's going to tell me off, or the doctor's going to do this. And I coach an under 10 girls football team. We had games this morning, and one of the dads is my patient, and he was like, oh, here she comes, I better not have one of those chocolates for Mother's Day because she's going to tell me off. And so I think we've got a bit of a reputation that if I go see the doctor, oh, they're going to stop me doing this, and it's all quite negative. And I think a lot of the work that's being done at the moment which I think is totally fascinating, with Prospector and the microbiome involving the whole food plant base and your sort of healthy gut. I think that is coming a little bit more to the fore, as opposed to don't eat that, don't sit there for 8 hours a day. And I think that it's a little bit more now than just calories in, calories out. And there's going to be, it's to do with the way that some people eat and don't get sick, and then other people eat a certain way and they get really sick or they put on weight. And it's, I think, the sort of upcoming field of the way that we all sort of process foods and the gut inflammation and the health of our guts is not going to be about calories in, calories out. It's going to be sort of almost like a personalized nutrition. But we'll have to sort of wait and see on that one as an emerging field, which I think is going to be fascinating. But I think that if you're telling people to not eat cakes, biscuits, sweets, fried food, it's a very negative connotation, and that's a lot of comfort, quick fix, happiness that a lot of people are reaching for, especially during lockdown. I think within the first couple of months of lockdown, I was getting a new diabetic every week. It's just because of the activity and because we were at home eating, because it was a worrying time. And I think that you've got to cut people some slack, but it is about them making the little changes to become their new habits.
And I think it's not just about not doing something and it being negative. We often say to our patients, don't do this because you're going to put on weight or you're going to have a heart attack. But we're not explaining why. Why would that be problematic, actually? When we do explain that to our patients, actually it improves their understanding, and they know that they can then make that informed decision for themselves.
I think you're completely right here, Erica. I think one of the things is explaining why. So not only now you're diabetic or you have heart disease and you should just stop eating X, Y, Z. But why? What I found in emergency medicine, quick consultations, very useful, is changing the narrative of not what you should be reducing, but actually giving them a solution, what they should be adding. And immediately the consultations become very, very positive. So if I focus on cutting out what they love, what do all of us do? We immediately start rebelling against it. But if I tell them you have a choice, you can either add beans, lentils, very hearty stews made out of these amazing legumes, added with a lot of mushrooms and spices. And after that, if you still want to eat your usual food that gives you comfort in your mind, you're more than welcome to do that. But first, why don't you add a little health to yourself? And then you can make a choice if you still want to eat the foods that actually fuel disease. And I think in the Western world, we too often want to be reductionist in our approach rather than adding solutions to our patients and changing the narrative on what they should be adding instead of what they should be reducing. And Elizabeth, you just said that we have been at home eating a lot. Well, we were in A&E and in GP practice, working all day, all night, but our patients were at home eating a lot, and thus it became a problem. If they would have been eating the right things, the foods that are in the blue zones that we are talking about every day, they wouldn't have had a problem. They could have eaten that the whole day long, and their bodies would have organized, limited to the amount that they need, right? So I think it's very important to start adding the what and why rather than removing the foods and becoming very reductionist in our approach. What do you think about that?
Yeah, absolutely. And I think that people are very receptive to explaining that to them. The consultations that I have, especially when faced with a diagnosis of type 2 diabetes, because that's sort of, we get into sort of the driving, with the DVLA, and that can affect people's livelihood as well if they're drivers. It affects sort of travel insurance. It's got huge implications for people. And, I love it when people say, well, what can I do? What can I do? How can I change this? And then some people don't, and you just sort of say, well, you have, but you can do something about this. This isn't final. This isn't the end of the story that you have type 2 diabetes. I'm hoping the end of the story is that you have gone into remission, or you have diabetes resolved. That's what I want to code you as, diabetes resolved, and we'll just sort of move on. And then you can have some very rewarding consultations with patients for both of you, about surrounding lifestyle and about engaging with that and keeping well and reversing this, because it's explaining it to them. It's about the insulin resistance, sort of the weight gain and the central fat distribution, with the high lipids, and that your cells aren't absorbing the sugar like they should because of the insulin production from the pancreas. So if you can try and sort of explain it in simple terms, and that this is what is happening, and the high sugar level can cause sort of damage, and they invariably know, often a family member, or they invariably know somebody that's got the diagnosis as well, because it's very common. And then to try and have that initial consultation with somebody. Some people are just like, oh, okay, take some tablets. Some people are just sort of resigned to it straight away. And it was just like, when you sort of start speaking to people about, actually, it doesn't have to be like this. You don't have to take the tablets. We can do something about this. Let's see what we can do. And I think that within the limitations of general practice, trying to engage somebody for that short time. And then I also have, very lucky, I've got a couple of nurses that are trained up to do diabetes, and we're very accessible. So if there's any issues or any problems, then they can call in and speak to one of us, which I do appreciate is difficult, because as you've all heard, and I know at many points during the pandemic, the wait to get through on our phones was 50 minutes to an hour. And you know what, I'd give up after that unless I needed urgent medical attention, if it was just a routine matter. And it is really, really hard. So I think that's been a bit of a barrier to people engaging with it. But just having that initial lifestyle consultation can be groundbreaking for somebody, really, and they really want to engage with it. Sort of like the two, just an example of the two participants that I've had, and I've had another gentleman that was, I think he was up at about 120, his hemoglobin A1C just recently, and you just sort of say, well, what are you doing? How are things going? And he was eating 4 magnums a day. How does anybody have the time to eat 4 magnums a day? You were doing what? You got into the habit of eating 4 magnums a day. And you sort of say to him, well, we can help you out. It'd be quite easy for you to turn this around. If that's what's caused the issue, then we just need to help you adjust what you're doing from a lifestyle point of view. And we're going to have to find something that you really enjoy as much as a magnum in order to go ahead with this. And, you know, it's trying to get people to engage with, actually, after your meal, rather than having a magnum, could you just have a handful of raspberries for me and see how you get on? And it's just sort of breaking that sort of habit, really. So I'm still waiting to hear after the advice that I've given him as to how he's going to do with his magnum habit. But there are people that still eat like that because they think it's normal to do so. And it's trying to engage with those people and trying to find out in the kind of initial consultation when they've been diagnosed, where along the line has this occurred? And it's also getting them to admit it as well, because some people actually know but are quite embarrassed, and what's even harder from a professional point of view is that they don't want to change and they don't want to engage with it.
I think there's a strong narrative around the fact that we say our patients don't want to change, but I find it that our colleagues and ourselves before weren't really giving the solution for them and the practical advice, and we didn't even ask them on a regular basis if you wanted the change. I think that's one problem, and the second is that we very much ingrained the idea that these lifestyle-related chronic diseases are actually genetic. So there is this very strong undercurrent narrative that both physician and patient often believe that they cannot make the change. Once you're a diabetic, forever a diabetic. Mm-hmm. We don't have the prescription scripts. We don't have the prescription guidelines. We don't actually engage with our patients to say, if you went on lifestyle changes on a regular basis in our practice, you could actually get off of your medications, because that's very empowering to know that not only could you just get better with your diabetes, but me as a physician who understands the physiology is telling you that you can get off of your medications, and it has nothing to do with your genetics. When the patient retaliates and says, well, my grandmother and great-grandmother all had genetics, just highlighting the fact that both your mom and grandma and so on also had the kitchens in the house with the same cooking style. They often kind of think twice, like, oh yeah, that's true, we are eating the same thing. That's why we are having the same disease. I think these small key quick consultation techniques, which we could teach to all of our medical students, and then junior doctors going up into specialty and GP practice. So both care lines, we have to repeat this constantly so we all sing the same tune. Wouldn't that change how our NHS is doing? Yes, Erica.
Yeah, I think one of the first things we should be saying to our patients when they are diagnosed as pre-diabetic or with type 2 diabetes is, you can reverse this. That should be one of the first things we say to them, rather than, hey, I can give you some medications to control your blood sugars, which is often what we say to our patients. And I wondered, Liz, how have your patients been taking it when you've told them that this is potentially reversible, especially people who have been living with type 2 diabetes for a long time, like your patients with the HbA1c of 132, that didn't just go to 132 with no time.
Yeah, no, absolutely. They've wanted to engage, to do something about it. I mean, the gentleman in particular, he didn't want medication. It was like, I don't want to take tablets for this. Medications have side effects, which they do. But he said, I didn't want to take tablets. What can I do? And he was quite fortunate that I just finished my CHIP training at that time. I said, will you come on this journey with me and we can try and change it? But at other times, people, they need the guidance and the support.
Are they surprised that it is reversible?
Yes, because they think that once they've been diagnosed that they're kind of on that path and they have that label. Yes, they do. And I think there's probably not enough education out there to sort of say that it is reversible. I think that you actually have the ability to do something about this, as is, sort of cardiovascular disease, it's sort of controlling your lipids and your weight, and it's all connected, isn't it? It's all part of the same message to do with lifestyle, that if you do make some changes and if you are willing to engage with this and we can help you with this, then it can be reversible.
And I think it's important to also highlight that, yes, medications can help maybe to an extent to control your blood sugar level, but that would never reverse your diabetes. And the only thing that is able to put your diabetes into remission is actually lifestyle. We need medications. We're not against medications, and we need it in certain situations, but very often far too often it's the first thing that we reach for, both as clinicians and as patients.
Yeah, I mean, if they haven't got any, sorry, Linda, if they haven't got any what we call osmotic symptoms, so the weight loss and the thirst and getting up in the night and passing water a lot and being very tired, then I try it, and the hemoglobin A1C is at a good level, and try and engage with them and say, listen, you can reverse this without medication. If they are sick, like the gentleman that I had, the patient that I had, then it's just like, yes, you can reverse this, but I need to get you at a level with your sugars that it's not doing damage anymore and you actually feel better to engage with this. So he actually did need to start medication, even though he didn't want to, and then work at reducing it, and then work at reducing down the medication and coming off it. So there's definitely, the two approaches are valid, but I think the overall message should be that you can reverse this. And if I do need to start medication for you, that it isn't forever. you can do something about this and you can reverse it. It is possible for you to do this. I've got another gentleman that I inherited that's been a type 2 diabetic for quite a long time. And I had a chat with him because he was just on more and more insulin and more insulin. He was a type 2 on insulin. He's been through the medications. And again, during lockdown, he actually decided to do something about it and started walking with his wife. And they had a little group that they would not walk together because of the restrictions, but they all went off walking every day, and almost a competition to see who could walk the furthest. And he's come off his insulin now. So insulin, again, isn't the end of the road, because he's made all these lifestyle changes, and they ate very well, and his was about activity. So he's become more active just with walking, just putting on a pair of shoes and going out for a walk every day, and reduced his weight, and he's actually come down and off insulin. So I mean, it's not forever. It can be reversed, and you can get a handle on it, and it's not a diagnosis for life if we can educate people and empower people and employ the kind of lifestyle medicine ethos. I think that, you know, it's not something that's for life, even though, as you said, Linda, it does run in families because they've got the same kitchens. but yeah, you can make changes, and it can be reversed, which is great. For chronic disease, that's just phenomenal.
It's in A&E especially, I mean, we cherish drugs. They are fantastic for acute situations. We can save lives within minutes. These are the peaks, the acute presentations of these chronic diseases that you guys are seeing in GP practice over years. And unfortunately, they end up in an emergency setting on my table with a side effect, with an acute presentation, which could have been addressed over the last whole lifetime, or at least 5 to 10 years when we first picked up the disease, and even before with the right education. And this is why we are here, because we were very frustrated with Erica, and we started with you, Liz, from the beginning, talking about how could we actually help the NHS and our patients get this education. And this is when we started with Afternoon Tea with Docs, where we can offer a platform where we hope in the future the NHS colleagues will be referring their patients onto the platform, where for free we can actually guide them on how to implement these changes. And now I started referring my patients from A&E, where I give them a quick prescription on lifestyle, you know, eating canned beans, broccoli for the week, following it up. And one of my patients, who is now an Afternoon Tea community area, immediately started making the changes because he felt the support, and he got that first inkling from a doctor, like from you. I feel it's very, very important for him to believe that it's possible, that we believe in them. And the last 4 months, I've seen his blood pressure plummet. He has just been sharing all his photos of his food, and they have been doing it with his wife. And not only that, now it has actually progressed to his colleagues and the construction site. He has been doing very well, inspiring his colleagues on eating better, actually brought a water fountain into the building site so that they stop drinking Coke and Fanta. So it's really infectious. He started feeling better, losing weight. His blood pressure was going down. We're just going to repeat his HbA1c to see how he's doing with his prediabetes. And I hope that we can do these changes on a larger scale, and that you will have a platform where you can reach more patients, because your work is just incredible. I mean, look what you have achieved in such a short time, just with a bit of education. And we hope that we can, together as NHS colleagues, we can come together and push forward with full force. Hopefully, the message will come across. Are you hopeful about the future?
Yes. Yeah. I think that getting the message out there, and I think people are willing to listen, and I think people on the whole want to feel better. And if you engage with the pillars of lifestyle medicine, if we can educate people and empower people and support people as well to engage with it, then I think that they're going to reverse their chronic diseases, and I think they're going to feel good, and they will reap the benefits of that. So I do. I think I wholeheartedly believe in the lifestyle medicine approach, and it should be first, shouldn't it, really? And that's what we should be trying to promote, both in general practice and in hospital.
We do talk about the patient a lot and how they get better, but don't you feel more fulfilled and feel like you have a real mission in life?
Yes, yeah. I mean, it's a lovely consultation to have with somebody when you can educate them just with simple measures, really, and they feel galvanized to engage with it. And especially during this time, you get some job satisfaction from that, because there hasn't been a lot of that in general practice over the last couple of years. And I'm not the only one. I think I speak on behalf of all of general practice by saying that morale is very low, and to have somebody positively engaging with you and getting some positive feedback, and hopefully, I mean, we came into this job to very simply sort of, as you put it, sort of help people. And that's what I still believe in and still want to do. And this is a way of engaging with that and doing that without drugs. So it's just wonderful if we can educate people and empower people to make those lifestyle changes. It's great. And it does give you a great sense of satisfaction when you can impart that knowledge to people.
Yeah, I mean, for me, I've been known to call my patients in at the end of clinic if I want to give a proper kind of lifestyle medicine consultation. So I know that I can spend an hour with them if I wanted to, and just to actually hear the hope in their voice that, oh my gosh, I can do this, it's possible, I don't have to be on drugs forever, and that I can actually get better from where I am now. Just simply that sound of hope in their voice makes it all worth it.
Yeah, absolutely.
So we got win, win, win. The patient is winning, our sole purpose of our work and all our studies. The physician is winning, as well as the NHS, because we have less patients, more satisfaction on both of our patients and our physician side. So what more could we ask for? When are we going to start actually prescribing lifestyle medicine on a regular basis to our patient is the big question. And hopefully stories like this is going to inspire the NHS and other patients to actually ask for this on a regular basis. Thank you very much for this incredible discussion. Before we go, what are the 3 practical takeaways that our listeners here on Zoom and on YouTube can take away to start living and transforming their health?
I think the first one has to be, as you've alluded to, about nutrition and about your diet. And I think making the little changes, switching over, for example, the red meat for the beans and the pulses, just make those little changes across, and instead of deep frying things, steaming, grilling, I think those little changes with your nutrition so you feel better. Try some new foods, try some new vegetables and fruits and beans and pulses. And I think just engage with eating the best that you can for you to feel well. I think then as well, just trying to incorporate activity into your day. Drink some more water so that you need to actually walk to the toilet more. It's just little activities. It's just kind of get up out of the chair every half an hour and just move, I think, so that you are not sedentary. Because I heard a phrase the other day, sitting is the new smoking. And we all need to get up and we all need to be moving a little bit more. And then I think that it is hard. It is hard to try and get this message across. And I think that if you can engage with making the small changes in your lifestyle every day, then over a very short period of time, they become your new habits. And it's about forming new habits and moving that healthy lifestyle, the sort of lifestyle medicine practice forward on a day-to-day basis.
Very sustainable and practical takeaways. Thank you so much, Elizabeth. You're also starting or already doing a menopause clinic. Could you tell us a little bit more about that, and where can our patients find you?
Yeah, that's actually just changed this week. I do menopause as part of general practice. I've just finished the Confidence in Menopause course as well as the British Menopause Society theory course. So I'm now undergoing my advanced practitioner training, which is great. And I did set up in a private practice. I set up my own clinic with Summerfield Healthcare. And now this week, I've just found out that I have got a menopause specialist role at Newson Health, which is just fantastic. And I'm absolutely thrilled. So I will be moving from Summerfield over to Newson Health sort of about May time, but also continuing to do that and the lifestyle medicine, which can be applied to menopause and all aspects of health as well.
Congratulations, incredible work, and our patients are really lucky to have you. If they wanted to find you on social media, can they reach out to you?
Yes, yeah, sure. Yeah, I'm on, I think some people have already found me on Instagram. There's not a lot of lifestyle medicine on there, some photographs and bits and pieces, but I'm more than happy. I'm on Facebook as well. Yeah, no problem.
And I think you're on LinkedIn as well.
Oh, I am. Yes. Sorry, I'd forgotten about that one. There's so many, aren't there? Yes. I'm on LinkedIn too.
What is the handle for it?
Oh, do you know what? I will find out.
I think it's Liz.
I think I'm Liz Pearson on there. Yeah, at Liz Pearson.
Liz Pearson, yes. I think
somebody's found it. Well done.
There are not enough channels to find you and your incredible work. We just need to promote it as far and as wide as we can. Thank you so much for the incredible work that you're doing for reversing diabetes and showing how it's done just because you care and you take the time to do so. After this session, we are going to have a 30-minute group coaching session and a chat with those who have joined us here on Zoom. And if you guys want to engage with us next Sunday, you can get your Zoom link on Eventbrite and find us on afternoonteawithdocs.com, where you can see all of our upcoming events, the free community and members area, where you can actually see your progress in your lifestyle and achieve your health goals. So thank you for joining us. We hope to see you next Sunday.